I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking to Paul Ginsburg, president of the Center for Studying Health System Change. We're discussing recent Massachusetts legislation that's aimed at lowering healthcare costs in the state. Dr. Ginsburg, Massachusetts passed health reform legislation in 2006, and that served in many respects as the model for the Federal Affordable Care Act. The Massachusetts legislation succeeded in expanding coverage, but it hasn't controlled spending. Is that result surprising, or was expanding access the major goal of the 2006 reform?
Yes. Well, my understanding of the 2006 reform was that, those people that came together to enact it were fairly explicit that they would defer cost containment issues for the future because otherwise it would have been too difficult to get it all done in one piece of legislation. They did create a governor's commission and charged it with coming up with recommendations to control costs, but it's not surprising at all that costs weren't controlled because really nothing was put in place to control them.
And of course, costs have risen in Massachusetts. Do you anticipate that costs will rise in other states when the ACA's expansions in coverage come into effect?
Well, actually, yes. And in fact, the cost increases could be even larger because, the proportion of the population gaining insurance under the Massachusetts reform was smaller than will be the case in many other states with the national reform because Massachusetts had less to go to achieve the goal of universal coverage. Massachusetts started out with a very high rate of proportion of people having insurance. So in a sense, the system-wide impact from expansion of coverage was smaller in Massachusetts. And now, much of this spending increase that will come from the expansion of coverage, we shouldn't see it as a bad thing. I think we should see it as a good thing. Because if we're, taking a population that is very limited in their access to care because of being uninsured, and we give them insurance and they're able to access care, we're presuming that a lot of the additional use of services that comes about is going to be fairly valuable. Now, we all know that not all increases in healthcare spending are positive things. And, that's why Massachusetts, having achieved all the positive aspects of increases in spending, are trying to grapple with the negative aspects of it.
Massachusetts has consistently had some of the highest per capita healthcare spending in the country. What drives that? Is it high prices or high usage?
It's probably both. I think Massachusetts has a high-income population. They are demanding of more services. Something that, from my experience, is somewhat unique in eastern Massachusetts is the degree to which the public prefers using teaching hospitals or academic medical centers for services that are fairly routine. And I think this is a factor that also leads to costs being higher in Massachusetts.
In addition, by law in Massachusetts, insurance must cover a number of benefits, perhaps more benefits than in many other states. Is that also driving up spending?
That's probably been led to consistent higher spending, although I don't know the magnitude of it. But definitely Massachusetts benefits mandates are higher than average, and in many of the services that are mandated, you have a situation where covering these services is going to lead to much higher use of those services. But as far as percentages, I doubt that it's a major driver behind costs being high.
In a recent Perspective article, Ayanian and Vandervest discussed the new Massachusetts law to contain healthcare costs, and the approach they describe the law's taking is multifaceted, but perhaps the most significant component of it is the goal that public and private healthcare spending together not grow any faster than the gross state product. What kind of tools does the law provide to meet that degree of constraint?
Well, over the many months that this law was developed, and I've been called by reporters from time to time, I'd always been struck at how much energy seemed to be going into deciding what the goals should be, as opposed to what steps would be taken to achieve the goals. And, my reaction to the law is, very ambitious spending goals, very little in the way of concrete tools that would lead me to believe that these goals would be met.
Having said that, what tools do you see in the law that might be effective in controlling costs?
I see much of the law as what I would call a jawboning approach to regulation, basically exhorting providers and insurers to slow the rate of spending increases and, having provisions to embarrass, particularly providers, whose spending increases continue to be very high or whose prices are very high. But I don't see, it's almost like setting the stage for another law that might come in 2 or 4 years, which might push more concrete steps than this year's law has.
In fact, one criticism of the law is that it lacks teeth to enforce its components. Is that a fair criticism? Do you see the bill as falling essentially short?
Yes, I am completely in concurrence with that assessment that this bill does lack teeth. As I say, it's really, the bill communicates aspirations and has plans for a lot of collection and publication of data on costs, but doesn't appear to have concrete steps that are likely to contain costs.
Coming from the other direction, to the extent that it does succeed in containing costs, is it liable to have adverse effects, for instance, pinching important medical resources or driving away healthcare business from the state?
Well, I believe that Massachusetts is at the point where additional spending on services delivered to Massachusetts residents probably hurts the state economy rather than helps it. In fact, there was an excellent article in the New England Journal of Medicine a few months ago by Kate Baker, an economist, explaining why additional health spending is typically not the source of economic gain. So I would think that the fact that healthcare costs are so high in Massachusetts is really dead weight on the Massachusetts economy. Now, I said services to Massachusetts residents. On the other hand, if they're treating people from abroad, that boosts the Massachusetts economy. Or if there is biomedical research or research funded by the federal government or other sources, those aspects of the health business, I won't call it health care, are clearly positive to the economy. But I think the business of providing health services for local residents is not a boon, but really a weight on the economy.
There's also active debate about cost containment at the national level. To what extent do you think federal policymakers will be watching Massachusetts and this law, and to what extent will its successes or its failures be replicated nationally?
Well, actually, I don't. I'm sure that national policymakers will be looking at the law, and I think policymakers in other states, particularly northeastern and mid-Atlantic states, will be watching. But I suspect that when federal policymakers start focusing more intensely on costs, they're going to do it more as purchasers. In a sense, they're going to be zeroing in on the Medicare program, although realizing that as they zero in on Medicare, they don't want a result where Medicare costs are just shifted to other payers, that I think they recognize that they can't solve the Medicare cost issue without addressing the healthcare system as a whole. But I think that there would be less following of Massachusetts in the area of cost containment than there has been in the area of expanding coverage.
Thank you, Dr. Ginsburg.